My name is Madeline Grady. I'm a resident at UCSF in San Francisco General, and today I'll be sharing our project, Discharge Navigator, Impact of an Electronic Decision Tool for Social Resources Upon Discharge. Many patients have unaddressed social needs that significantly impact their health. In emergency medicine, alongside our treatment of acute medical conditions, an essential part of our practice is considering the underlying social determinants. However, navigating the landscape of available community resources and their eligibility requirements can be complex for both patients and clinicians, especially at times that social workers are unavailable. Our team aims to create a digital decision tool to help clinicians identify and link patients to social resources upon discharge. We sought to make our tool customizable, utilizing each patient's clinical and demographic information to actually tailor recommended local resources, as well as actionable, providing clear next steps for clinicians. We also aimed to evaluate the impact of this tool on clinicians' knowledge and confidence in caring for patients with discharge needs in domains such as housing and substance use. We arrived at this objective through an iterative design thinking approach with a multidisciplinary team, including designers, physicians, and medical students. We interviewed our key stakeholders, which included EM physicians and social workers, and identified key barriers to referring patients to social resources. The most cited barriers here in the box were awareness of local resources, particularly those tailored for specific subgroups of patients, eligibility requirements, a lack of time, a lack of convenient materials to hand to patients, and language barriers. After benchmarking current sites and apps, there really was no existing tool that met our needs, so we built one. After a series of iterations, we implemented a digital tool called Discharge Navigator, accessible in one click through our electronic medical record. The internal architecture is built upon decision trees, created in coordination with social medicine topic experts at our institution. These organize resources according to key clinical questions, such as the duration and acuity of need, or whether patients belong to specific demographic or clinical subgroups. The result is this tool that takes these key inputs and allows the clinician user to actually filter resources accordingly. Here's an example for substance use. Up at the top, you can select the type of substance the patient's seeking treatment for, and then you answer targeted questions about their needs. With each selection, the listed resources are updated in that blue box below to the most relevant ones for your patient. As you click to explore the resource, the tool actually highlights specific clinician actions for referral, any COVID-related restrictions, and also provides links to printable patient handouts in 5 languages. Here's another example from our new mental health module, which easily filters resources for specific patient subgroups and actually elevates those which are specifically tailored to them. So in this example, community resources focused on mental health care for HIV positive patients are highlighted at the top of the output list. Our patient handouts include key information for each community resource, including how to get there, contact information, and the type of services provided. We were careful to consider sustainability and up-to-date community resource information. So we partnered with students from a volunteer organization with an aligned social mission called California Social Resource Database, allowing for sustainability of future updates. Institutional and local grants also helped fund handout design and translation services. So next we evaluated our tool. During the 12-week study period, there were between 4 and 81 unique site visitors per week, which translated to as many as 40% of on-site clinicians. Of those, 55, a response rate of 40%, completed our post-implementation survey. Respondents were 58% residents and fellows, 34% attendings, and 8% nurse practitioners. A majority of respondents found the tool easy to navigate, felt that it improves access to relevant information, efficiency on shift, and reduces stress during discharge. Over half use the tool at least once per week, and a large majority plan to use the tool more frequently. The average likelihood to recommend score was 7.8 out of 10. For our primary outcomes, we compared clinicians' self-assessments of key competencies that were pre versus post tool implementation. The launch of our tool yielded a statistically significant increase in all domains, with all p-values below 0.001. These included awareness of homelessness and substance use resources, confidence in accessing these resources, a knowledge of the eligibility criteria, and ability to refer patients to relevant resources always or most of the time. So there are a few key take-home points I'd like to discuss and to make this presentation as useful as possible. And while I have this slide up, feel free to visit our website using the QR code there to use the tool yourself or you can visit edrive.ucsf.edu/dcnav. So in summary, we successfully designed, built, and implemented a custom digital decision tool for social discharge resources, which was regularly utilized by clinicians in our public tertiary emergency department. Importantly, our results validate Discharge Navigator as an effective educational tool at our institution. A big reason that the tool had such positive outcomes and satisfaction is because the end user and physicians themselves were consulted in the design process. Our outcomes on that last slide show that the tool directly alleviates the most cited barriers that they previously identified in our early interviews. We highly recommend taking an iterative design thinking approach to tackling similar problems at your own institutions and to iterate with input from your end users. The main limitation of our evaluation is a lack of direct patient outcomes. While survey respondents did self-report an increase in their ability to refer patients, there's not currently a closed loop process in which we can actually track the number of patients who follow through with those referrals. This is an important area of focus for future development, as ultimately our aims for interventions such as this one to translate into tangible patient impact. Finally, we hope to illustrate that the tool is easily replicable at other institutions, so feel free to reach out to us to discuss how you might do something similar at your hospital, or share with us tools or interventions that have already worked well in your settings. The end goal is that Discharge Navigator and similar tools may help build a community of EM clinicians who regularly incorporate social determinants of health into their patient care. Thank you for listening. A huge thanks once again to our team at UCSF and SF General, and I'd be happy to take any questions.